Global Oncology Masterclass Series, which is a free open access learning platform designed to empower oncology trainees and professionals. We want to provide everyone the resources so they can enhance their clinical appraisal and research skills. So we have 3 modules based on biostatistics, critical appraisal, and enabling research. So feel free to join and feel free to be part of this masterclass series. And as part of this commitment, we are launching our master classes on the 27th. So I also invite you guys to join as we are going to do some introduction, some overview of research methods and overview any statistics. So everybody is invited to join. I'm not the star for the webinar today, so I want now to hand over to our moderators so they can invite our speakers. Thank you all again for joining, and thank you all for giving us this opportunity. I hope that we have a great session today. Thank you.
Thank you so much, Fabio, and it's my pleasure to introduce my friend and my colleague, Dr. Werner van der Poos. He's a clinical oncologist at the National Center for Therapy and Nuclear Oncology and Nuclear Medicine at Kolebu Teaching Hospital in Accra, Ghana. She's also an adjunct professor at Queen's University. We all know Werner as a leader in African oncology. She helped and led the current landscape of research and education and policy in Africa. Werner will talk about strategy of capacity building through education and faculty development program in global oncology. So, Werner.
Thank you so much, and welcome everybody. Sorry, my internet is really misbehaving, but just give me a few minutes, it will come right back. So I'll share my slide. I think, let me see. Okay. So we've already talked about educational programs. Can you see my slides, please?
Yes, if you put them in a slideshow mode, that'll be great. Yeah.
Yeah. Okay. So I'm going to start with the educational programs that everybody has talked about, the critical appraisal, global oncology, grand rounds, and then through the common sense oncology, which is also part of the program, we review to improve service delivery. And then there's also faculty development that I'm going to talk about. So let's go straight into it. Why faculty development? These programs aim to improve technical skills, curriculum development, career progression for African cancer clinicians and researchers, addressing barriers like insufficient local support, funding, and access to training. AORTIC engages on several platforms, fostering a collaborative environment for cancer control in Africa. In fact, I was trying to get who said this, but I guess couldn't find it again. But in fact, anyone who does training, teaching, managing teams in sub-Saharan Africa can be considered faculty, even if they are not associated with an academic institution. So what it is that in Africa, things are a little bit different. Unlike in North America, where most of these teaching institutions are attached to universities, we still have issues where we have teaching institutions that are separate from the universities. It makes it a little bit difficult, but most of what we do is almost equivalent to what happens in the university. Yes, and of course, we are missing out on programs like didactic guidance and how to teach your faculty and how to assess other training modes. So workforce training is unparalleled in cancer control. Without that, we are missing out. I think we tend to concentrate a lot on early detection and all of that, but we all forget about workforce training. I think it is the missing link. It started with a grant from the Royal College of Physicians in Canada through Queen's program, through Nazik, and she roped us all in. Models were developed by Queen's in collaboration with faculty with African flair, so it wasn't just one-sided, Online models were developed on program evaluation, education, scholarship, leadership, career development, promotion, teaching, and learning. These are things that we don't get in our regular institutions outside of the universities, which are very, relevant for training the next cadre of cancer specialists. So the themes were leadership skills, gendered aspects, socio-cultural norms, mentoring strategies and techniques, how to adapt them, promotion and development, how to thrive, and pedagogical innovations and curriculum development to explore, to engage, and then learn experiences from each other on how to do that. Because we had a lot of young faculty who need to be taught this again. I'll say it again, we don't have these programs where we are. So we had an invitation to join the faculty development study in 2020. And then there was a faculty development workshop at the AORTIC meeting that year. There were qualitative study interviews. We presented this at the ASCO 2021. What we knew about the barriers, enablers, and satisfaction among African oncology faculty. What we found was that African oncologists face many challenges and are dissatisfied with the current state of their faculty development. There was access to local institutional support on opportunities, including funding, were limited. There were reduced fees for individual for LMIC for conferences, but it still didn't make up for the shortfall. And then getting time off work, your institution was also a big problem. And then availability of online faculty development education enables them increase the participation in these faculties. And then again, we're in CASHO 2024, also with various themes. I'll talk a little bit about that later. And there was a publication to this effect in the Journal of Cancer Education in 2025 about what we did on the continent. So the recommendations basically was to have structured programs of evaluation and assessment of the faculty, institutional mentoring, cross-international collaboration, and then reduce the workload, because we had multi-specialties in one specialty, like clinical oncology. Right now, the burden is getting very high, and that might actually, increase your burnout load. And general oncologists doing oncology, it can be quite difficult for us. So I think these are things we brainstormed on to act on further. So let me go a little bit more into the sessions in AORTIC 2020. Burnout, we did a session on burnout. The topics covered were by several speakers: workplace, social factors, dual practice, was it a blessing or a curse, challenges and successes unique to women in oncology, celebrating the profession in African style, be proud and resilient. We also talked about love-hate relationship with academic institutions. Like I said, we are separate institutions, but it's the same teaching. And what do we do to make this better? We also talked about, do we want to be a professor after all, and what to do to make this happen? Developing your teaching dossier, which a lot of people don't know about, starting early and documenting everything, and what you can do to increase your chances of promotion in spite of all the socio-cultural hindrances that we have on our continent. So we also had a leadership webinar that was done in March of 2024. There were 40 African oncologists in attendance, facilitated by Miriam, and the speakers were many. The covered topics were team building, thriving in academia, young generation, ethics and motivation. And there were a lot of gratifications from this workshop. People love their work, they love to teach, and they consider it as a hobby, and people wanted to have international recognition, having a larger network, joining, these faculty development programs and AORTIC, academic career advancement and mentorship were things you get from faculty development. And there were also some drivers to developing yourself was you had, knowing that you have mentors who did more, so you can also achieve. You want to give a true representative of Africa globally, being a role model, and so many of these. At CASHO 2022, there was a workshop, Advancing Cancer Care Leadership in Africa was the broad theme. It was a very exciting, with a zeal of engagement. Some actually paid for themselves because there were not enough spaces, there was enough money to go around everybody. In total, there was 74 attendees, multi-speciality. The common ground was a lack of the succession planning in our institutions, and the feedback as to what works and what doesn't work, and exchanges to navigate the TEP. It was very, very gratifying. And just to tell you, the different countries, it was really important with a lot of people from different parts of Africa. So the key learning models were leadership skills, promotion and professional development, pedagogic innovations, and mentoring strategies, like I mentioned before. And these are just pictures to tell you what went on there. And that was Scott, Bumi, breakout sessions, which are we learned a lot, even as the facilitators, and we talked about career planning transitions in the African way and the hindrances that we see. So the main thing is succession planning. And In the AORTIC 2025, we plan also to have another couple of sessions there, and we hope to move this forward. But I think this is a very ignored topic, and I think I'm glad that we have taken on the baton. Thank you very much.
Thank you so much, Verna. This was a quick journey, but powerful, and hopefully you will engage with the faculty development program, and we need to bring it further. We will have opportunities for questions later on, so we will move on. And next is, I guess my nephew and my mentee, Dr. Fidel Bogumia, and he comes to us from the University of Rwanda. He is a consultant oncologist and director of research at the Rwanda Military Hospital. He's also an adjunct assistant professor of oncology at Queen's University in Canada. He is the founding program director of the medical oncology training program at the University of Rwanda, and he will talk to us about policy insight from fellowship work. He was a fellow, one of our best fellows at Queen's, and experience with Rwanda medical oncology training program. So, Fidel, go ahead.
Okay, sorry, I was muted. I didn't realize that I was muted. Thanks a lot, Nazik, for the kind introduction. And I think really the purpose of this is to show how global oncology programs at universities in high-income countries can actually help to bridge some of the gaps that we see in some, low-income countries. And here I will share with you, audience, how the Queen's Program Oncology Program helped us to establish one of the medical oncology fellowship program in Rwanda and one of the few on the continent. So as Nazik was saying, I was a fellow at Queen's for about 2 years, and when I was there, learned a lot in terms of medical oncology. As a background, I'm a clinical oncologist, so I did clinical oncology with a heavy focus on radiation oncology, but my fellowship was really medical oncology. And I felt like at the time of my fellowship, which was from 2021 to 2023, we still had few numbers of oncologists in Rwanda. And having been trained by people who are, into education mostly, that's Nazik and Scott, I had really a convincing that we should also start a same training program in Rwanda. And also, one of the things in the background was that where I trained as a clinical oncologist, it was an in-country training, and I had seen how impactful it was to increase the number of oncology in country in Tanzania. So during my fellowship, I started a conversation with the Ministry of Health, which back home is in charge of education for medical personnel. And this took time. So during the whole process of my fellowship training, it was a conversation on how we can start oncology fellowship program. And lucky enough, during that same period, the government had shifted to priorities in terms of increasing healthcare workforce. The government initiated 4x4 workforce initiative, which the plan was to quadruple the general workforce in the country by quadruple it in the 4 years to come. And so that really aligned with what I was planning in terms of starting oncology fellowship program. So, and during those conversations, really what was going on is to show the policymakers that there's a need to increase the number of oncologists because the number of cancers are increasing. We could see that whether using our local data, the Rwanda Cancer Registry, National Cancer Registry, or whether to use the global estimates, the global CAN data, the number of cancers are increasing, and hence there's a need to increase the number of people who are going to take care of those patients. So the data was important in terms of convincing the need for increasing the number of oncologists, but also the timing. As I said, it was a time when there was a reform to prioritize the number of workforce in general in the country. So putting in oncology was really a matter of time to that. Third thing that I learned during the whole process was that policy change also needs a relationship. So you have to really build a relationship between the policymakers and partners that you want to work with. And through that whole process, was a lot of meetings and revisions of curriculum or documents, proposals. And this shows you that to achieve any policy change, you need to have time, because it's going to be a long time that needs most of iterations along the way. So through that whole process, as I was still at Queen's University, and having been able to work with the people that are into cancer education, we started to draft some of the curriculum modules and curriculum documents with the help of the team, but of course involving the local team as well, because these are the people that were going to really own the program. And the whole process took a long time with, of course, as you all can imagine, multiple stakeholder meetings, reviews to approve the document. And fast forward those after 2 years, like 2024, that's when we first enrolled our fellows. And up to now, we have a total of 7, 3 finishing their second year. And we have enrolled 4 others in the first year as well. And what really, and that's why I want to go back to the purpose and role of global oncology programs in different universities in high-income countries, is that, as you can imagine, having few oncologists on the ground, it was going to be difficult to have enough faculty. And from what even Werner was saying, most of us are really not trained as faculty. So and this is something people always have, that when you're a clinician, you're automatically a faculty, but that's not the right thing to do, because you need really to have also training in terms of, in a way of how you teach, how you plan, all these in terms of being academician is not really straightforward. Being a clinician, that you have to be a academician. So because of the numbers of people that we had on the ground, we needed to have support as well from colleagues, whether in US and Canada, where we had contacts, at ASCO as well. We really benefited from this kind of relationship. We had a lot of faculties that are teaching virtually to my fellows, and also learned a lot from different other resources as well. So through this process, I would say that I have learned a lot of lesson, whether in policy making, because starting a program like this requires to align with the policy, but also to reiterate that it requires persistence. Persistence comes that if you get a no, don't take it as a no when you're starting a program, whether it's academic program or any other program. Partnerships is very key. I had a backup of people who have been in the space for a long time, and this increased the trust with the policymakers to make this happen. If you have to have a very sustainable training program, you need, of course, the curriculum, but you need collaboration and you need local leadership. A program that is really not taken up by the local team will not really be sustainable. So through all this process, Rwanda has now its own oncology fellowship program, thanks to collaborations, thanks to partnerships that we have created, and thanks to persistence to continue to find ways to increase the number of oncologists in the country. And here we are at ASCO with my 3 fellows, and soon we are going to be at AORTIC as well. Thank you so much.
Fantastic. Thank you so much. This is amazing work, and we're very proud of it. And of course, of your tenure as a fellow at Queen's with so many projects finished and done. So we will move to my other nephew and another CSO, another fellow at Queen's. So we will have Dr. Omar Abdelhamid, and he comes to us from Kenya. He is a consultant clinical oncologist, a researcher. He leads the Garissa Cancer Center, which is the first and only oncology facility in northern Kenya. And he's done a lot of work in policy and research, and was a fellow with us at Queen. So yeah, go ahead and tell us about global care partnerships and policy implication.
Thank you, Nazik, for the kind introduction. Yes, there will be more nephews to come, I hope so, following the footpath. So my name is Omar. I'll be talking briefly on, I only have 10 minutes, I'll keep it short, on global cancer care partnership and policy implication. And as a disclaimer, I really want to say there are more people experienced to talk about global oncology on this call. But nonetheless, just wanted to talk about on a one-liner on the overview of some of the cancer collaborations and how it can really impact most of our cancer care landscape in Africa. And also I'll touch on, I was requested to also mention, my personal experience on the fellowship that I just finished at Queen's. I have no any disclosures. So I think this has been mentioned several times. Whenever we talk about partnership, even in their own home state, it's all about partnership, and win-win model is the best way to go. And the global cancer burden is rising fastest in the low and income countries, as you all know. So transfer of really cancer care skills, research, advocacy, from high income countries or even South-South collaborations actually is really what partnership and policy should be, and not only vertical sharing, but horizontal sharing in terms of the policy is also equally important. This is the striking global or data that you always see, but I want you to focus on the right side where it's not about the cancer numbers, but the resources allocated. You see in high income countries, they do have fairly, lower burden, but a high, resources they pump into the cancer care landscape. Conversely, in our own backyards, we see high burden of cancers and our resources really not at par at what we should be doing. And this is why our own partnership, even locally, should really push through. And, some of our own local governments needs to do better than what we are doing now. Again, win-win, but the policy here is, whenever high-income countries try to really have partnerships with low-income countries or vice versa, I think there's simple principles, and I've not pulled this out of my own mind, but it's actually a ASCO Global Oncology Principle, a whole paper that was published that I pulled this out from with the help of AI to summarize it in figures. So it just says do's and don'ts, build trust, share decision making, communicate openly on the interest and the purpose of the collaboration in terms of the cancer care landscape, ensure mutual benefits, as really this has been really a bit of historical, most of the benefit has not been bidirectional. And some of the things is we really not to make sure that you don't exploit, low-income countries, or even, being cognizant of decisions, really not good. Should be bilateral decision and for marriage. Speaking of that, in terms of the research, is one of the domain that you actually see there's a lot of differences in terms of a lot of inequity in terms of the high or low income countries. Fidel, Nazik, and most of the people, Melinda on this call, actually, and I were part of this work, and we were trying to really describe what actually an equal partnership in terms of research in the African cancer research ecosystem is like in terms of disparities. Funding is an issue, publishing, where to publish is an issue, a type of research, who actually does the bulk of the work, who gets the credit. And I really invite you to read this paper, and actually it will summarize of all how the partnership should really be healthy. Some of the actually good, successful global collaborations actually need to be, as to be fair to them, need to be actually to be mentioned. IEA actually does a lot of work in radiation, and resources, and implementation. City Cancer Challenge, WHO, UICC, Atomic Max Foundation, a little bit of NCCN Harmonize, which I'll leave you to actually digest if that really a lot of people have comments on that. Reyes Cancer, National Cancer Grid, for example, of the India example, and the WHO initiative for Cure for All. Specifically for IAEA, actually, it's really improved in the uptake of the of radiotherapy machines. And case example is my own backyard, my own center, which was really, IAEA really took a big part in terms of collaborating with Kenya to set up decentralized radiotherapy machines. And this is also, I think, we don't have pediatrics. I hope there are some on the call, but this has actually been touted as a very good program for most of African countries, especially for the access to some of the drugs. But I think this has really been a very landmark in Kenya. I don't know about other countries, but the drug access to imatinib, which is a very highly curable disease in terms of the accessibility to this life-saving drug, has been really good. And if you see on the right side, actually survival has really increased over the years with the access of this drug. So this is a very good classic access program for global partnership in terms of where these drugs are really needed most and where they save lives. But again, policy levels for a lot of African countries, it's not really how it should be. We do not focus on the right thing. This should be a guiding, staircase, essential medicine list of our own drugs, especially the ones that are cheap and accessible and that are proven to save lives. Universal health coverage. We still have issues with cancer registries in our systems and the national cancer care plans. In the order of hierarchy, these are really some of the things that should determine actually the type of global global oncology partnerships in our own countries. And another facet that has already been talked about is fellowship. Actually, this is another part of making sure that global oncology and partnerships are really bridging the gap, as Fidel said, and part of which I was part of the fellowship that I was lucky to be part of is the Common Sense Oncology, but also there are others out there that any of the fellows or any of the young doctors who are on the call can really apply to the UICC, the ASCO Fellowship, IEA Fellowship, ESMO Fellowships, and even our own AORTIC, ACLI, Africa Cancer Leadership Institute, which I was part of for the last cohort. So all these are some of the opportunities that actually can bridge the gap for global cancer collaborations and partnerships. So finally, I just wanted to say that these global partnerships, as much as we need them, need to have laws and MOUs for it to benefit everyone. It's good to co-define priorities bi-directionally and what the collaboration of the oncology is all about, and funds for training, the less, where most of the young guys who really want to be part of research, training, and funding is a big issue. So I think if it's really something that can be thought about in terms of, motivating the young African researchers in cancer, co-publishing is really important as part of equal partners. And, even the type of research should be something that really the outcomes can really affect our African problems and even, global problem to be specific. I'll move on swiftly to this, my fellowship experience. So Common Sense Oncology, I wanted to put a plug in. A lot of people have heard about them. There's a whole website about it. It's really a movement that's concerned about, inequities of cancer care around the world in terms of the evidence generation, evidence interpretation, and evidence communication. Basically, outcomes that matter to patients and their families is what the CSO is all about. And it's also, that's, I think, also tied at the hip of global oncology and partnership that we're talking about. These are the founders of Common Sense Oncology. Some of you might recognize yourself, including Professor Nazik and Fabio and Fidel on this. But this picture has actually grown bigger than it is right now. A lot of people around the world have joined the consortium. Here was my first and last day at Queen's, first on the right side and the last day at Queen's when I got my fellowship under the stewardship of these able gentlemen, Professor Chris Booth and Professor Timothy Hanna. So the culmination of my fellowship was one of the projects that I was assigned to in the 6 months, 7 months as I was there, and led to actually publication of that in the accepted as an ASCO poster session, and finally just published in the European Journal of Cancer, which I'm really grateful to these gentlemen right here, Professor Ian Tanek, Michelle, Chris Booth, and the whole team. I didn't want to talk about what the paper was all about. Maybe we'll touch that at some other time in terms of masterclass on clinical appraisal and trials. So thank you so much.
Thank you so much, and congratulations on your work and your paper. And so we will move to, again, this time one of my favorite nieces. So from nephew to nieces, and I would like to introduce Dr. Melinda Mujguna. She is a radiation oncologist and assistant professor at Queen's University. She did her undergraduate and medical degree and specialty training in clinical oncology at the University of Zimbabwe, and subsequently her fellowship at the University of Toronto. And now she is an academic oncologist at Queen's, and she will talk to us about the radiotherapy capacity and training. So, Melinda.
Thanks, Nazek, for the kind introduction. So my name is Melinda. I'm a radiation oncologist practicing here at Kingston General Hospital. And I always mention that I'm a Zimbabwean trained, clinical oncologist. So it's an honor, really. Okay, my slides are not moving. So I've no pertinent conflicts of interest, and I'm going to be focusing on radio capacity and training and some projects that we've been doing with our collaborators in Africa. So just an overview, in Africa, the mortality to incidence ratio was 0.64 for cancer. And therefore, this translates to 64% of people diagnosed with cancer tend to die from it. And radiation therapy, as we know, it's an essential tool in the cure and potentially can cure up to 40% of cancers. And in palliation, probably more than 50% of people will need radiation as part of their treatment plan. Therefore, just looking at this map, which shows in terms of the distribution of radiotherapy machines, mostly concentrated in the north and in the south, and noting that only 4% of the world's radiotherapy machines are in the entire continent of Africa. It's therefore important to optimize radiotherapy utilization in line with the resources that we have, but also propagating innovations in radiation therapy when we are able to do that. So just focusing and being guided by, in terms of our working pillars here at Queen's Global Oncology, our mission statement for the radiation oncology pillar is optimizing and advancing radiation oncology skills in line with evolving technology. And this we do guided by our working core values, which really respects cultural values of partnership institutions and evidence-based, which is culturally, aligned, and bidirectional, learning. So I divided this talk mainly into addressing global radiation therapy gaps by focusing on the policy pillar. And two, I will go briefly into training initiatives and collaborations that we've been involved with through the education and research pillar. So in terms of our policy, two main campaigns and movements that we're heavily involved as Queen's faculty was in the Choosing Wisely Africa. So the first conference really was, was completed in Senegal, just prior to the AORTIC conference, which later on in the following year. And we did dwell into Choosing Wisely, focusing on the radiation oncology, aspect. And this led to one of the publications under the guidance of Dr. Fidel, whom I'm really humbled to say is one of my main mentors, essentially. So in terms of Choosing Wisely, it really did focus on adoption of hypofractionation in the tumor sites where we do have a solid evidence base. And most recently, we have transitioned to focusing also on common sense radiation oncology, which focuses more on, how there's a rapid uptake of certain radiotherapy innovations, but these may not really meet some of the immediate needs of income settings. So that balance really needs to be, explored. And therefore, Queens is one of those in terms of strong giants in focusing on what is common sense when you're looking at radiotherapy overall. So moving on to training initiatives, there's this important paper which was led by Prof. Nazik and Prof. Scott, which looked at oncology training education initiatives in low middle income countries. And this was a scoping review. And one of the findings was that oncology training and education initiatives in low middle income countries are really central in building workforce and provision of excellent care to cancer patients. And that includes quality radiotherapy. So as a targeted, intervention as follow-up to some of this important research, we do, participate in educational sessions which are focused on propagating innovations, those transitioning from 2D to 3D to IMRT and VIMA, just depending on what stage and level of transition an institution is, as we are also cognizant of some centers who are like having the most updated radiotherapy, machines. So doing or having those knowledge exchange sessions to optimize on this new, techniques is in the forefront of what our global oncology team, in terms of what we intend to achieve. We also do work with residency programs where we are complementing the on-site teachings with virtual lectures or even some practical, interactions as follow-up to virtual teachings to consolidate on radiotherapy techniques as well. We have been participating in regional AORTIC speakers series, and most recently, we did have a good and a good engagement when we did host the lung radiation oncology series, and it was quite humbling to note the gap that there is in lung radiation therapy overall. And there's going to be a session on this as well at our AORTIC conference. So I'm excited to be part of the team. And we've also been involved in the Best of ASCO team as well. And as part of this intention in terms of sharing knowledge, we also are open to radiation oncology observerships at Kingston General Hospital. Currently, these are self-funded, but you're hoping that in future, we may be able to look for funding. Then we have more people who can come and we can really do that exchange, bi-directional learning with practical in-person teachings. So when it comes to research, we have also been doing lots of collaborative research, which is radiation oncology focused. And one of the important work, which was also led by Dr. Fidel, was on status of peer review in radiation oncology. And one of the conclusions was that it's imperative to develop implementable and comprehensive guidelines on how to conduct peer reviews in resource-constrained regions such as Sub-Saharan Africa to ensure quality radiotherapy. So it's a challenge for us now to say we have this data now, how then do we transition to making this come to life such that at the end of the day, the main goal is, are we able to give quality radiotherapy to any of our patients in Africa? Just focusing on more research as well, which was led by a number of our Queen's faculty were involved in. We do work with other programs, and namely Clinical Research Mentorship Program. This is a Princess Margaret initiative, but you find a number of faculty from Queen's and other peers from Africa also involved in mentorship roles as we try to cover the gap in mentorship, which was highlighted in one of the studies that was led by Miriam and Prof. Nazik, which looked at challenges faced by women oncologists in Africa. And mentorship was something that came out of one of the findings. So an important project that is close to my heart, this is a study that we did, prospective study in Black women exploring dermatitis, after noting that internationally, this is an understudied population. So it's humbling to note that we can do prospective studies, Black women in Africa, that can actually inform international practice. And it was exciting to work with other international peers. through this study and having our patient advocate for this study being involved in, some policy projects that we are doing. And I recommend that you be on the lookout for those, yet to be published. But I think in the next year or two, we should be having them published. So that is all I have, and some of the publications that we do have from the different projects that we have done from a radiation oncology capacity as Queen's Global Oncology faculty. Thank you.
Thank you so much, Melinda. This is exciting, and I actually coming out of this, there is the Atlas for Oncology. That's another program that is upcoming, which is the Dermatology Atlas in Oncology, looking also at chemotherapy side effects. So I hope everyone will be involved. I think we initially thought this was a 90 minutes program, but it seems like 60 minutes. So what I'll do, I'll try to go over my presentation very quickly, and hopefully people can spare another 10 minutes or so over so that we can answer some questions. So let me share my presentation, which takes you into another different area, which is part of it is to one of the goals is to see how we respond in our collaboration to the new realities or emerging realities in the continent for Africa. So we're looking at a cancer care in conflict zone, collaborating to address cancer in emergency setting. And if we look at the data from UNHCR, we know that 123 million people now in the world are displaced, forcibly displaced from where they live, from their homeland or even outside their country. And therefore, 1 out of 67 persons in the world on Earth are living as displaced people, whether internal displacement or not, and that the displacement have nearly doubled in the last decade and has increased. And so one of the realities that's often not mentioned is that Africa remains the continent with the largest number of people who are forcibly displaced, accounting for 43% of the global total, almost like 50%. So that means it's almost maybe 50 to 60 million people in Africa are displaced. They do have cancer care needs, and this was double the figure in 2016. And contrary to what people think that all refugees are running to Europe, 96% of refugees actually stay in Africa and don't take the boats to Europe or try to come to North America. And this is my favorite refugee of all. This is my father, who's now a refugee in Rwanda. I'm originally from Sudan. And in April 2023, when the war started, he is now a refugee in Rwanda, and he's one of the lucky refugees because Rwanda is safe and I can support them, but most of other refugees do not have the similar resources. And despite that it's more than 2.5 years that I could not bring him to Canada. So it tells you like Africans are treated differently than others. And we know, and one of the reasons is that 35 armed conflicts in 16 countries are happening in Africa. And if you look at from the UNHCR, Sudan and the Democratic Republic of Congo produce one of the largest producers of refugees, now is a smattering of some countries like Myanmar in Asia. And the Sudan crisis, the war in Sudan, is the world largest displacement crisis in the world. And this is a good map because it tells you who is producing the displaced people and who are the host countries, which is something we want to concentrate on because people who become refugees and they have cancer, they need to seek care in other host countries, and there's not a lot of attention paid to these host countries. For example, in the Ukraine conflict, a lot of attention was, addressing needs in Poland and Romania and elsewhere, or in Syria, a lot of attention and help was given to Turkey and Jordan, but Uganda and Kenya and Rwanda, there's very little attention given to the burden that the refugees can cause in these centers. So I'm just going to go over some of the slides because of the lack of time, but you can see how external displacement has increased, and you can see from 2017 to 2025, it's almost doubled. And all of this burden is affecting displaced people because cancer does happen to displaced people. And we have addressed this in several other conferences. Why the spotlight not on Africa? Some of it internal factors, because we emphasize infectious disease or trauma. There's mismatch between cancer as a public health threat and its position in priorities. There's weakness of cancer leadership within the continent, but that's improvement, and weakness of the relationship between African Cancer Organization, African Union, and the CDC. So no representation of cancer in the peace agenda. The weakness of research and infrastructure. The research priorities are not really sometimes addressing the needs of most of Africans. So these 60 million people and the host countries, we have very little data. And also weakness of crisis preparedness measured at the level of the National Cancer Control Plan and Ministry of Health. And conflict zone are countries that have little or no cancer care available, such as Central African Republic or Chad or South Sudan, often secluded from international partnership. But as I said, the story of Central Sudan should make people aware that this can happen anywhere. External factors, a bias and outright racism against Africans, the fact that the international and global cancer community likes to work with places that are stable, geographically desirable, have safaris and everything, political factors such as the marginalized status of many of these countries, such as Mali and Sudan. So I've shared these slides 2 years ago, and I still keep it, because 2 years ago when we started looking at this, you could put in PubMed and you put cancer and conflict and cancer or war, you can find there's 494 publications from Ukraine. Somalia, there was 0, but maybe 2 that we're not including a PubMed, and Sudan was 4. And so it tells you such a disparity. And in response to that, we created the African Organization for Research and Training, a significant interest group in cancer in conflict zone and other humanitarian settings. We tried to position ourselves within the discourse and the global scene of cancer in emergency. So we participated in the manifesto of improving cancer care in conflict impacted zone that was led actually by Dr. Tedros, who is the WHO leader. And we have 7 recommendations. Part of it is being part of the WHO working group, having strategies for care models for cancer patient in humanitarian setting, develop specific strategies to deliver better cancer care for conflict-impacted population, and establish cancer care as a core pillar in emergency setting. This is one work that I did with Fidel as a commentary on the radiotherapy, updated radiotherapy Lancet Commission that was in the Lancet Oncology. And what we said was that conflicts are a major barrier to developing radiotherapy in the first place, and fragile state that a lot of them are in Africa, such as Somalia, South Sudan, Chad, and Haiti, have very minimal capacity or no capacity, such as Mali or Niger. And ironically, these are the places that need the radiotherapy more, because patients that are diagnosed at a later stage. And with the lessons that we see in Ukraine and Syria and Gaza, there's a lot of regional and international support for radiotherapy machine, online technical peer review, evacuation of patient, and provision of access to radiotherapy free for refugees. What determines your actually support for radiotherapy is how strong your neighbor is. So the regional capacity, the geographical distribution, if the neighboring countries have a lot of capacity and universal health coverage, then refugees can get access, which is not the case in Africa. So for example, in Uganda, 1.8 million refugees are now in Uganda, and the number of machines is not enough for everyone, including the host country. We have participated in integrating cancer into crisis, which is the WHO working group and mission. And so we looked at conflict in the acute phase, in the protracted phase, and I encourage you to read about that. We also talked about how the African Organization for Hereditary Cancer is coming together to address the data and logistical issue of responding to cancer needs in Africa. We are also trying to address one of the causes of conflict, which is climate change. So as you can see in Darfur, in Western Sudan, where there's now that conflict is actually raging a lot, this is considered the first climate change conflict in the world, with a convergence of environmental, political factors, and it has spread throughout the Sahel region. And so we are coming now with where we came together in AORTIC, and we have the AORTIC Statement on Climate Change in Africa, which is a partnership across the continent. We discuss confluence of climate injustice, resilience, and opportunities, because Africa has a lot of opportunities to incorporate environmentally sustainable models. And I am glad that we have leadership in Choosing Wisely and CSO, which will also help in those sustainable models. And our manuscript is in preparation. We have now a survey that I encourage all of you to send out today, investigating therapeutic geographies in Africa and looking at the perspectives of oncology professionals about who provide care for displaced population in Africa, and we seek to understand the landscape of cancer care for displaced persons. So I encourage you to go right now and fill that survey, because we need a lot of data to convince the stakeholders. Cancer and war matter. Displaced people have cancer needs. Cancer does not know whether you are in a conflict zone or not. And 86% of deaths from NCD happen in LMIC. Most people stay. 96% of refugees stay in Africa. So even my dad is still in Africa 2.5 years after the crisis. He's still a refugee there. And most refugees stay 20 years outside their countries, and the average length for the internal displaced is 10 years. So my last slide. So we need to put cancer agenda on the agenda for peace. Let's harness our collaboration within Africa and our partners. This is just came back 2 weeks ago from Uganda, and this is a session, an awareness session for some of the Sudanese refugees over there. Lots of work to be done. And we want to see you at our SIG session in AORTIC, Tunisia, and also at the London Global Cancer Week. And really, we need to collaborate more and produce more data and knowledge and best practices. So I'll stop sharing here. And I think we can take another 5 to 10 minutes to answer questions, see if anybody has a question for the panel.
So thank you, Nazik. As people are trying to gather their thoughts and their questions, I just, again, thank you for putting 90 minutes. I know you're all prepared for 90 minutes, and putting it into 60 minutes is not always easy. And honestly, 1 hour is never enough, because when everybody comes to present, there's a lot to talk about, and 60 minutes just runs by fast. Like I said, Prof is going to speak now. Like I said, in Tunisia, we have a session for this, where we have to come, the North American collaboration. I think it's November 4th or 5th, where it's 2 hours. We are going to be talking with each other, having a discussion with each other. I will share this information for us to please join. This is the time where people are against diversity, people are against people of color, people are against global research, diversity research, and everything we are doing. And we have to come together and see how we have to address this collaboratively. Prof, please, over to you. You're muted, sir.
Christopher Williams.
Okay, this is Chris Williams here. I'm talking from Canada, from the West Coast. I'd like to congratulate the organizations of this event. It's been very informing, and I just have one question. We've always known that training is a very important strategy for cancer control in Africa. There's no question about that. And that is what we were actually thinking about when we created AORTIC 43 years ago in 1982. That is why we called it AORTIC, the African Organization for Research and Training in Cancer. At that time, however, the concept of global oncology was non-existent. In recent years, there has been a kind of a proliferation of institutes of global oncology this and that. And so I'm wondering, what exactly is global oncology? Can anybody define that for me? Tell me, and what part of the world is involved in globality? In my view, global is one of the most misused words in medical care. When we take journals and look at publications, say, oh, well, we just finished a global study. And you look at who was in this global study. You don't find a single African country in it. Oh, we just finished a study on the hepatoma, the greatest killer of people in Africa, and you don't find any African countries, and yet it's a global study. And now we're talking about global oncology. What exactly is global oncology?
So thank you so much. I think I'll take the lead on this, but I just want to say it's a debate that's ongoing. If you live in Sudan, what's happening in Canada is global oncology for me. So it's all, and also, our disparities in our own backyard is also called global oncology. But in this model today, at least most of the presenters are from Africa. And even because I straddle both worlds.
That's what makes it global.
To us,
is that Africa global?
Well, because this is a partnership between Canada and Africa. There's a lot of things people have learned. Like, for example, if we look at the climate change thing, there's a lot of models that Africa can teach the rest of the world. So I think I think choosing to answer that question right now will be more difficult, but we are all aiming for equitable, for when we talk that it's really the drivers of knowledge generation should be from LMIC if this is a true global oncology partnership. I see a lot of hands up. I think Patricia started first, and then we have Rosaline, and then maybe Fabio. So Patricia?
Prof, sorry, Prof. Nazik, can I quickly say something to Prof. Williams? So one other thing that you also pointed out was the lack of African representation on global clinical trials. And for the clinical trial SIG that I co-chair, one of the initiative, and I hope you joined the clinical trial SIG session, I think it's on November 4th, is we have some pharmaceutical industry who are willing to do what we call proof of concept trial within the African continent. So that's one. And then one of the sessions we want to do is to kind of reflect amongst ourselves. There's been a lot of training on clinical trials. Where are we at and what are we doing? And then I was able to get a collaboration, if you will, where Big Ten, the Cancer Consortium and the Alliance Consortium are willing to partner with us as far as getting pharmaceutical industries to be able to do clinical trials in Africa. So pretty much just join us.
That is extremely important. And I'm happy you're making progress in that, because that is what Africa needs.
Yes, sir.
You need to do your own research. And you would see, of AORTIC, the AORTIC Hematology Oncology Research Group. We're going to have 3 sessions in Tunisia, and I hope you would. And I'm glad to know that now we may be making some inroads into pharmaceutical industry situation, because that is the only alliance, in my view, that would make AORTIC grow. That is what make made aortic grow in the 80s with the, anyway, we'll talk more about that. But I'm very happy.
Indonesia, and there's a lot we're going to talk about Indonesia. So hopefully we'll give some of the people who have participated in this opportunities to ask. So we'll go to Patricia.
Can you enable my video? Nobody can see me.
Yes, we can't see you.
So you can see me? Okay. What happens is the most important thing to my mind is screening, because you get the most bang out of the buck in terms of survival. You folks should not be chasing after all those expensive whatever drug or scans that are available in developed countries. Look for those cost-effective ways to do things when resources are limited. Thank you. And I want to say hi to Dr. Williams.
Oh yeah, it's so nice to see you, Patricia. We're old buddies from where was it now? Regina, Canada. Anyway,
yeah, I will send you email. I will send you email later. Let's listen to the conference.
Thank you so much. I think prevention is part of even when we're building training programs. That's part of it. Is also they are the leaders who are going to take care of most of the prevention measures. So next is Rosaline. Yes, please.
And thank you for the insightful presentations and even for the opportunity to ask my question. Having listened to the presentations, I've noted that we lack capacity to do quite a number of things, but I appreciate the collaboration. So my question is, if we experiencing the conflicts like Dr. Nazik has explained, have we also considered bringing in mental health to handle the conflicts that patients with cancer? You know, cancer in itself brings a lot of mental health challenges. Then comes the conflicts and displacements, and then there's cancer. So I'm just thinking maybe we need to consider a strong perspective of mental health wellness for the patient with cancer, if that has been considered in those places.
Thank you so much. I think when it comes to conflict, we're scratching just the surface in terms of what services people need, all the way from prevention and just to, for Patricia, from the HPV, the disruption of HPV vaccination, and that's happened in some of the conflict areas, all the way to most all of the psychosocial distress that the refugees and displaced people experience. And so that's hopefully one of the projects that we're going to, with some of the host countries, we're going to start looking at those things. I see Jamal Saman. In the meantime, Fabio. Okay.
Thank you, all the teams of AORTIC. Yeah, can you hear me now? Yeah, thank you, AORTIC and Common Sense Oncology. I'm from Somalia, so my question is how AORTIC and Common Sense Oncology can help to develop a radiotherapy service in Somalia. As we know, Somalia, in Somalia, there's a lot of conflict. So how can Common Sense Oncology and AORTIC and Global Oncology can help us to develop radiotherapy service? Thank you.
I will leave that to Omar.
Yeah, that's a very tough question. Jamal is a young, very active mentee of mine. We're currently doing some work on esophageal cancer from the first ever study in Mogadishu diagnostic centers on the burden and the outcomes of esophageal cancer. He's right. There's no single center of radiotherapy, or even, I think, maybe one oncologist in the whole country of Somalia. A lot of strides need to be, taken through. I'm not sure if we really have the correct answer, but I think advocacy is where we can start as a voice of young people like Jamal and who have interest in oncology, and putting out data from Somalia. I think that will be a starting point to show the unmet need that they have. And probably, and also talking to the government stakeholders and through AORTIC in the advocacy SIGs, maybe to highlight some of the burdens that we have and the lack of access to such problems, such solutions to oncology care.
Omar, I just wonder if you can actually start thinking about tapping from oncologists in developed world, because I have some colleagues that we trained together that I know that from Somalia, either the first generation or the second generation immigrants in this country. You know, at the end of the day, we say charity begins from home. So if you can want to go back and give to a society that either trained you for nothing or trained your parents for nothing, I think, again, we can collaborate. And I try to do this by talking to ASCO to see if they can share the information of international medical graduates, right? Like myself, you know, that is part of ASCO. We can kind of reach out to all these people to see if they want to go back home to support, or if we can mobilize ourselves to try to see fundraising for countries like this. And one other thing is trying to collaborate with ASCO and Dr. Nazik. I don't know how far you've gone with that, to actually shine a light on cancer and conflicts, especially on African soil. Because I was in the room when they were talking about the conflict in Ukraine and how loud they were. Can we actually get that same I know that you're already smiling. Can we get that same action from ESMO, from ASCO? Because we've always had conflict. Nobody says anything. Ukraine has conflict. All of a sudden, everybody's talking about it. Can we get and shine that spotlight and kind of, for the lack of better words, shame people to actually be able to speak on this? I don't know. I think I'll leave that to Omar. You just got an idea what. So I know you have all these ASCO people as colleagues.
Briefly, yes, that's what we're trying to do. But also, we need to come together, because a lot of the support that was given to Ukraine and was given to Syria were from the neighboring countries and through the EU, supporting these neighboring countries through, the Eastern Mediterranean, supporting Jordan. And so we need also to come together, provide data, liaise with the CDC, with the African Union to try and create some African solutions that will put our problems on the map on the world map. So Fabio, you wanted to say something?
No, I was just gonna touch on the point what is global, but I think we are past that discussion. I'll let you guys have some great discussion in Tunisia. Yeah, that sounds good.
So are there any other questions? I think people can go to the Global Oncology website at Queen's, and you'll find the modules. They will find, and those are the masterclass. And a lot of the presenters here from Omar, Fidel, and of course, Werner will be, the people you know, everyone will be in Tunisia, but if not in Tunisia, we can meet through the AORTIC channels. And of course, I encourage you to do our survey for the conflict. Yeah, any final thoughts, Fidel, Omar, Werner, before we end? Thank you. The lots of people who attended, about 70 people, so that's wonderful. It's good to see many friends here. Fidel?
Yeah, no, I don't have much to add, but the numbers actually shows you how collaborative this group has been. So let's keep on doing this.
Werner?
Yeah, I want to thank everybody for joining here. And I think that it's the beginning of a lot of more work to be done. And I think we are open to your feedback and how to embrace Africa more. And I think I've heard everybody, but I think there's a lot of local talent in Africa that is being totally ignored. I know the first thing is to look out and reach out to high income, but there's a lot of local talent that needs to be developed, encouraged. And I think that is one thing that needs to be promoted by AORTIC in so many ways. Like Abiola said, even fundraising to help to develop these talents. We are disadvantaged in terms of our earning power, but that doesn't suppress our brain power. So I think these programs will help to improve things on the continent. Thanks.
With that, with these wise words about brain power, I will end the session. And thank you so much, Abiola, for your leadership, and also for Belmira and the rest of the AORTIC team, and for all our collaborators at the Queen's Global Oncology Program, and hope to see you all in Tunisia soon.
All right, thank you, everyone. So just one last thing. There's no session next month. We are all going to be in Tunisia. But in December, we have Toronto and Addis Ababa collaboration. So thank you again. Please join us every month. I know for the love of Nazik, everybody showed up. Nazik, you have to come back in December and bring your crowd. Thank you again, and see you next time in Tunisia. Bye-bye.
Thanks.
Bye.
Thank you.
Bye.
Bye.